My name is Ryan Coleman, and I'm a pediatric intensivist at Texas Children's, and 50% of my time I spend taking care of kids in the intensive care unit, and then the other part of my time I spend as a member of the pulmonary hypertension service, where I'm one of the attending physicians and the medical director of the Right Ventricular Failure Program that we just started down here at Texas Children's Hospital. We started the Right Ventricular Failure Program here to really focus on those kids who have progressive pulmonary hypertension despite being on maximum medical therapy, who are approaching the need for potential lung transplant, kind of looking at ways to better optimize their management. So whether it's looking at changing their medical therapies to a different regimen, or is it considering some sort of intervention? And if that intervention is a surgical one, such as placement of a pot shunt or a unidirectional valve shunt, or is it going to the cardiac cath lab for creation of a atrial septal defect, a ventricular septal defect, or trying to put a stent where their ductus arteriosus once was to offload the stress that the right ventricle is under and try to buy them some more time before they potentially need to go to lung transplant. So one of the things that we've realized over time is that while lung transplant is a great therapy and sort of the only therapy available for some kids, there are other options. And sometimes, if we can delay transplant for whatever period of time, overall it just adds to the total length of time the family has with their child. We know that the 50% survival mark for pediatric lung transplant right now is around 6 years. And so anything we can do to delay the start of that clock, only goes to benefit patients and their families. One of the challenges that we realized a lot of these families face is that when you are considering something as consequential as lung transplant, you really need to have a comprehensive multidisciplinary team that's there to help you not only with transplant, but also to talk about any other options there may be. Transplant is a very intense both medical procedure, and then it involves a lot of lifestyle changes afterwards, including potentially where you even live. And so what we aim to do with the Right Ventricular Failure Program is to work not only with our transplant colleagues, but we've got members from interventional cardiology, advanced cardiac imaging, palliative care, congenital heart surgery, representatives from pulmonary hypertension from the intensive care units. This entire group of folks get together to talk about these patients so that we can come up with a real comprehensive plan, including lung transplant, who's also a member of this team, so that we can try to create a roadmap for these patients to follow that may eventually get to lung transplant. But if we can do anything to sort of optimize their transplant status before they get there, or even delay transplant, we try to do that. They may ultimately need transplant, but we're going to work with them to try to find the best solution for that family. There are only a few centers in the US that really do the bulk of pediatric lung transplant. Texas Children's happens to be one of them. St. Louis is another big one. And same thing with pot shunt. There's really only a few centers that do them. We are sort of new to the arena in terms of doing pot shunts. St. Louis has the biggest experience in the United States, and I work very closely with Mark Grady, who's the director of their PH program there. And then Morgan Stanley up in New York, affiliated with Columbia, also has a big experience. And so Erica Rosenzweig is there, and she and I also work together. Undergoing these procedures is a very big deal, obviously, and performing a lung transplant following a pot shunt is not a straightforward surgery by any means. And so it can be a little bit more complicated. And so you kind of have to go in eyes wide open, knowing that if you elect for a pot shunt, it may make your transplant tougher in the future, or depending on how your pot shunt is performed and the surgeon's preference, you may not be eligible for a lung transplant. So there needs to be a lot of planning that goes into considering what type of intervention you're going to look at for these patients when their right ventricle begins to fail. Whenever we meet with families, first off, it's going to be a long day. And so we try to make sure that we've got plenty of time allotted for these appointments. The last thing you want to do when you're talking about something this serious is for anyone to feel rushed. So usually I donate my entire afternoon to this conversation whenever we have it. Sort of the goal is to figure out, number one, what are the parents and the patient's wishes? What matters most to them? What are their hopes? What are their fears? Where are they at in terms of their disease? Because I think one of the things with something like pulmonary hypertension that you need to be very cognizant of is that there is no cure for this disease and there's no right way to treat it. There are certainly things you could do that may negatively impact a child's life or their quality of life. And the patients that I meet with in particular are patients whose disease is pretty severe. And so the last thing I want to do is present them with information that ultimately they're not going to be using or things that may sound scary. What we instead want to do is figure out exactly where the family and the patient is, and then take that knowledge and use it to help craft a care plan for them. We'll talk about all the different options, but when I start with kind of tell me where you're at and tell me what your big goals are for the next stage of your life, I'll use that as kind of the guide to then figure out how much to get into with each of the different therapies and sort of what are the options. Some families are very upfront and they say, I'm really nervous about transplant. What else is there? And then we'll spend time talking about shunts. Other families may say, we've read a lot about this and we're really interested in going forward with lung transplant. Well, then I kind of shift my role to how can I help make sure you get to transplant as healthy and as in great of shape as you can be in before you get there. It can be a very challenging situation when parents and the child are on a different page. One of the things that's most important, especially taking care of kind of the teenage patient population, is that you give them a chance to have a voice in their care. Because even though they may be 12 or 13, 14 years old, they're often wise well beyond their numerical age. They've been living with this disease for a while by the time I meet them, and they know inherently what they are comfortable with and what they aren't. We'll give them time alone with myself and with the other members of the team so that they have the opportunity to express exactly what they're feeling without worrying about upsetting their parents. It's amazing to me, and I think one of the great privileges we have as pediatricians is being able to interact with kids, these kids who have these amazing hearts and are so concerned about their parents, right? We always think of the parents as being the one to protect and care for the child, but it's amazing how many times it's actually the child who's also trying to care for and protect their parents from the bad things. And so we try to give them first and foremost a forum to say what they really want to say. And so they get some time alone with us. And then we do the same with the parents. Are there things the parents want to tell us that they don't want their child to hear? Or are there questions that the parents want to ask us that they don't want their child to hear? So we give each member of the family their own space. Usually, when you think that they're on different pages, if you give them some space and talk to them separately, you can figure out where the disconnect is and get them realigned together. Thankfully, knock on wood, I haven't had a situation where both sides are just dug in on, opposite sides of what they want. But my approach is always the same, give each person a chance to say what they really want and what they're honestly really afraid of. And you can usually use that information to craft a plan that everybody in the end is most comfortable with. Sometimes we meet these families at birth, and what goes from being one of the happiest moments of their lives, welcoming this new child into the world, suddenly becomes a very scary moment when something goes very wrong. And suddenly the dream of that perfect child gets shattered. And so I think one of the great privileges of being a pediatrician is that kids are resilient. We may think we know what's going to happen, but it's not uncommon for the kid to prove us wrong. And so one of the things I try to do with all families is, give them as much information as I can, and be as realistic as I can about what I've seen and not seen, but never to the point where you take away hope. Because the last thing on earth you ever want to do is take away the hope of a family. And so, sometimes we have to shift that hope, and you go from the hope of having, a perfectly healthy child to maybe the hope of having, a child who stays very comfortable despite having to be in the hospital, or a child who your hope shifts to, well, let's just try to get home. If we can get home, that's going to be a big win. And so I never, ever want to take away anybody's hope. I just want to make sure that we keep their hope realistic, and that we set kind of reasonable expectations without ever making what's already a challenging time for a family even more difficult. I think the dream, right, is that in some ways the hope will drive the science. Anything and everything we do for any kid, whether it's treating pulmonary hypertension or a kid with a bad infection in the ICU, everything we do is to stop the disease, stop the bad thing that's happening to this child and their family. And as we learn more and more about pulmonary hypertension, for example, the genetics of pulmonary hypertension are just mind-blowing. Even the genes that we test for, when I first started learning about pulmonary hypertension as a fellow, the numbers are rapidly expanding in terms of the panel that we send today versus that we sent 6-7 years ago. And so I think as we learn more about the causes, we learn more about kind of how this disease behaves, because it's still a relatively young one in the grand scheme of things. We'll find new targets and new things that we can try to change. And so our hopes initially were to just get these kids to live. When people first started treating pulmonary hypertension years and years ago, it's a disease that has 100% fatality. And so, back then the hope was just buying a little bit more time. Then the first line of drugs came around, and then suddenly we had a second line of drugs, and now a third line and a fourth line. And so our hopes are evolving and changing. And so now it's not just hoping for a year or two. Now it's hoping to get to college, beyond college, or hopefully one day eradicating these diseases. So it would be fantastic if hope drives the science, and then at the same time, the science can drive the hope a little bit too. And so as we get a better understanding of the right ventricle and how it responds to stress, as we get a better handle on how pulmonary hypertension develops, we can change what we hope for, and we can have bigger hopes and bigger dreams for these patients. And so I think kind of the two work hand in hand. And as long as we, as the physicians who get the privilege of taking care of these kids, are honest with families about what we can realistically do or not do, I think that's the best we can do in any of these situations. Every kid deserves a chance to leave behind a legacy. And one of the things that I make it a point to tell all of the fellows that I work with, whether it's on the intensive care side or the pulmonary hypertension side, is that you can't forget about the importance of a kiddo having a chance to say goodbye in the way they want to say goodbye. No matter how young they are, no matter what circumstances they come to you in, every kid deserves a chance to leave behind a legacy that's most important to them. At the end of the day, we have to make sure that no matter how aggressive we're being with medical therapy, that child doesn't lose a chance to impact this world in whatever way is most important to them. So I've had a child recently who decided to write a play that he had different members of the medical staff act out. Because of COVID restrictions, he couldn't have just a ton of family and friends at the bedside. So he brought the medical staff and child life and the physical therapists into his play. And so it's just remembering that behind every diagnosis is a human, and behind that human is a family. If you do that, you do it right. And that's what I'm really most proud of with the Right Ventricular Failure Program, is we're taking all the best advances in medical care and science, but we're coupling it with trying to really just provide 360 perspective on care for that child and their family. My name is Dr. Ryan Coleman, and I'm aware that my patients are rare.